I am so tired of having all these incident reports sitting on my desk because my nurses can't appropriately send off cultures to the lab. I just don't know what to do. I've written out the steps, I've gone over guidelines and procedures, I've had one-on-one conferences, I've had group meetings, my assistant managers and myself have discussed how we can go about preventing this problem from going on. We've gone as far as having nurses go to the assistant manager and asking if a urinalysis is appropriate to be sent off to the lab. None of these items were working, so we developed an algorithm to help assist our nurses in indicating if urine should be sent for a urinalysis or if it should be sent off for a culture as well. I'm going to focus in on this algorithm that was created last year in efforts to prevent unnecessary urine collection being sent to the lab. The key to the algorithm is that if a patient receives a Foley or comes in with a Foley to the organization, that it is cultured within 24 hours of the catheter being placed. Once the catheter has been placed and has been indwelling for greater than 72 hours, this becomes our issue. Because if a culture comes back positive with a catheter that is greater than 72 hours, we will be dinged with a CAUTI, which is not reimbursable by CMS, which is our core provider of reimbursement to the University of California at Davis Medical Center. The algorithm was developed to determine if a UA was needed or if a UA and culture, if indicated, was necessary. If the catheter is greater than 72 hours, a UA will be sent. If white blood cell counts come back greater than 5, then we will change out the catheter and a UA complete will be sent, which a UA complete indicates that a UA with culture will be sent to lab. If it's less than 5, no culture is indicated and will continue to monitor that patient. So the basic problem that we were encountering at the university was unnecessary lab costs associated with cultures. It's much cheaper to send off labs, to send off a urinalysis rather than a culture. Another problem was that if a suspected UTI was present, our policy was to treat with antibiotics empirically while cultured were pending. So we weren't being good stewards of our antibiotic use. Another problem was that we were not getting reimbursed by CMS for false positive cultures. It's becoming quite costly, up to upwards of $2 million per year for the University of California at Davis. So why did I bother in creating this algorithm? I created this algorithm about a year ago to identify a user-friendly pathway to teach my nurses on how to culture urine appropriately. Also, I developed the algorithm to prevent falsely identified UTIs. If a patient came out positive with a fever or signs and symptoms of infection, it was typical to pan culture or to culture blood, sputum, and urine. Unfortunately, urine collection wasn't always properly collected, and we were coming up with false positives in our urine cultures when indeed the infection was from another source. Another rationale was to be good stewards of antibiotic use. As medical professionals, we need to know that we're treating proper organisms, and our policy was to treat with empiric antibiotics until a culture came back, if it was positive or negative. And the last but not least rationale was to diagnose and treat patients that were in need of antibiotics and the proper antibiotic use in a timely fashion. Like I said, the key is collecting urine within the first 24 hours of admission to a hospital. If the urine is not collected within 24 hours and the patient has an indwelling fully on admission, we will automatically be dinged by CMS. Questions that I was being asked was, when do I culture? Why do I culture? How do I culture? And patients were even asking, why aren't you culturing urine? Where's my infection coming from? I know that I've been febrile. I know that I have a problem. What's going on with me? And to provide an evidence-based guideline, which has been our algorithm that was developed based on core data from the Joint Commission, from CMS, and from comprehensive studies, we decided to hand this out to our patients to indicate why we weren't culturing their urine. Measurable outcomes for the project were to decide, we were doing chart audits to decide if cultures were being sent appropriately based on white blood cell count analysis. Nurses were still sending off cultures inappropriately, sending out culture urine and culture if indicated instead of just a urinalysis. Extensive review of the algorithm was performed, and we have noticed much improvement on these audits. Another step that we took was to correctly identify if, based on white blood cell count, if a culture was being sent post white blood cell count population and EMR. Both nurse and physician were responsible for following up with this result that would pop up within 20 minutes of being sent to lab. With extensive teaching, the audit rates have been extremely low on non-compliance. So you can see from this chart that over the past year, we are reduced in our CAUTI rate, and it's likely to be related to the algorithm in which proper cultures are being sent to lab. One of the questions that's come up with the algorithm is that it's a possibility that we're completing this algorithm to prevent being dinged by CMS and the Joint Commission. However, the guidelines backing the algorithm are provided by the governing agencies, and we feel that it's best for our patient population that we follow the algorithm and treat with appropriate antibiotics than empirically treating with antibiotics as we had in the past. We've had better patient outcomes. I don't have charts to demonstrate mortality rates, but we've had improved mortality rates, less central line and CAUTI issues, and this has just been a great indicator that the algorithm can be used to benefit experienced nursing staff on how to properly care for our patient population.